to particular topics, specific topics in medical ethics. And probably the next time we get together will be when we'll do the session on the first humanities session, which deals with the two stories. And I know that some people, I guess the link was bad to Dr. Heidegger's experiment, so I posted a new Dr. Heidegger's experiment on the course website. So you can read Dr. Heidegger's experiment in its entirety, as well as the birthmark. Okay, any questions before we talk about professionalism? Okay, so the first, more or less the first hour, we're going to talk about something called the internal morality of medicine, and then the second hour, we're going to talk about professionalism, and these are basically two sides of the same coin. If you think about, if you go back to when we talked about the rules, the moral rules as formulated by Goethe, you remember that one of the 10 moral rules was don't neglect your duty, or stated alternatively, do your duty, okay? Well, what we're concerned about today is what does that mean when the duty that you're referring to is the practice of medicine. So that's what we're focused on today. So Brody and Miller, in an article that they authored back in the 90s, argued that the internal morality of medicine is constituted by the goals and the means of medicine. It's the goals and the means of medicine that make up the internal morality of medicine. And that, quote, professional integrity is constituted by allegiance to those goals and means. So they suggested that if you commit an act that promotes no medical goal, that you are violating the internal morality of medicine, or at best, you're engaged in a borderline practice. They also pointed out that an act might run afoul of the internal morality of medicine, not just because it doesn't promote a legitimate medical goal, but because the means that are employed are unacceptable. So they said, in other words, you can violate the internal morality of medicine either by having the wrong goal or by choosing the wrong means. So that, of course, raises the question, well, okay, what are the goals of medicine? Okay? It's the first question it raises. So back in the 1990s, the Hastings Center convened a meeting of experts, which I didn't get to go to. I wanted to go to Naples, Italy. I didn't get to go. But anyway, they had experts from all over the world. And what they asked the experts were, what are the goals of medicine? And these are the 4 goals of medicine that the experts agreed on. First of all, the prevention of disease and injury and the promotion and maintenance of health. Second, relief of pain and suffering caused by maladies. Third, care and cure of those with a malady and the care of those who cannot be cured. And then finally, the avoidance of premature death and the pursuit of a peaceful death. And you can probably tell that some of these things are worded a little bit vaguely, probably in order to achieve a consensus that everybody could agree on. But these are the goals that they came up with. Okay, well, you'll see that several of the goals reference disease or malady. Okay, that's important, as you'll see. So then we have to define what we're talking about when we say disease or malady. And this is a definition that was formulated again by Goethe, P of the rules. A person has a malady if and only if he has a condition other than his rational beliefs and desires, such that he is suffering or is at increased risk of suffering a harm or an evil. Remember the 5 harms that we talked about, the ones that the violations of the first 5 moral rules cause, in the absence of a distinct sustaining cause. Now, if that seems like it's a lot of words to describe something that everybody knows what it means, it really isn't. And everything in here has a meaning. So, for example, when he says, has a condition other than his rational beliefs and desires such that he's at an increased risk of harm, what kind of stuff is he excluding there?
Something you did yourself.
Well, no. Well, maybe. Well, for example, I mean, some people might like to ski, right? Well, if you ski, you're at increased risk of suffering a knee injury, right? Everybody agree with that? If you hang glide, you're at increased risk of suffering death, okay? But he says that that is not a malady. You can't say that somebody who's a skier has a malady. We're going to exclude, it doesn't make sense to say that they have a malady. So we're going to exclude that for the purposes of the definition. He doesn't have a malady because that's a rational desire on his part, okay? And in the absence of a distinct sustaining cause, what they're excluding, for example, is if a person comes in with a headache, and the reason that they have a headache is because they literally have a vise on their head, okay? Then that's a distinct sustaining cause. If I take the vise off, the headache goes away. So I wouldn't say that they have a malady, okay? Or if somebody's holding them in a headlock, it's not a malady. It's a distinct sustaining cause. In the article that Brody and Miller wrote, they also talked about, they had their own list of the goals of medicine. Their article came after the Hastings Center report formulation. What's interesting about this, though, is that they have some threshold goals there that you would think you have to have, right? So, for example, reassuring the worried well. Well, that makes sense. I mean, how do if somebody comes to me and I do a checkup on them and there's nothing wrong with them, was I engaged in the practice of medicine? Everybody would say, well, yeah, right? But because you don't know that there's nothing wrong with them until after you do until you evaluate them. So there has to be this threshold. This has to be legitimate. So that's an important thing, I think, to take away from their formulation of the list. So then they ask themselves, okay, well, what about the means? What are the means of medicine? And this is the stuff that Brody and Miller came up with. They said technical competence, avoiding fraud, avoiding patient harm, staying loyal to the patient. And if you think about it, I don't know what you guys think, but I'll tell you what I think. I think that these aren't means so much as they are limitations on means, right? They're limitations on the means. So I think we need a better definition of what the means of medicine are. And I think that if you want to find the best definition of the means of medicine, you just look to the law, okay? And you look to this is an old case from New York State, but it has a very good explanation of what the standard of care is. And we're going to talk about the standard of care when we talk about medical malpractice. Physician is under an obligation to exercise the same degree of knowledge, skill, diligence, and care that the ordinary competent practitioner would exercise under the same or similar circumstances. Okay? So the thing to take away from that definition is incorporation of the words knowledge and skill. The physician possesses certain knowledge and skills that the non-physician, or the PA possesses certain knowledge and skills that the non-PA doesn't possess, okay? And so I would suggest that a physician or a physician assistant employs medical means when he or she uses medical knowledge and or skills in the pursuit of some goal, all right? Medical knowledge or medical skills. So suturing, IND, again, diagnosis of community-acquired pneumonia, whatever. Okay. So now we have the goals of, we have the internal morality of medicine, we have the goals of medicine, we have the means of medicine, okay? And that should be sufficient. But what we're going to see in a second is that medical futility, which is an important concept that we're going to talk about, seems to throw a fly into the ointment, because medical futility doesn't seem to fit neatly into either category. It doesn't seem like there's a problem with the goals, and it doesn't seem like there's a problem with the means. So there seems to be something missing. I'll explain what I mean when we get to it. Let's talk about medical futility. Do you guys know who this is? Anybody who studied Sisyphus? That's Sisyphus. Okay? He's pushing the rock up the hill. And this is Adam. Who is it? What did you say?
I said maybe it's Adam eating the apple.
Well, yeah, Adam trying to eat the apple. Yeah, no. If you remember the story, Eve gave it to him, right? And Eve isn't in the picture here. So yeah, this is Tantalus. This is Tantalus. So the story with Tantalus is that, and that's where the word tantalizing comes from, is that he did something, he offended one of the gods or something, I don't remember who, probably offended a goddess actually. And he is condemned to eternal thirst and hunger. And so whenever he tries to take a bite of the apple recedes from him. And whenever he tries to bend over and drink the water, see this is water down here, whenever he tries to drink from the water recedes from him. So he can't drink and he can't eat, okay? So what these two things have in common is that both of these mythological characters are engaged in futile acts, okay? Sisyphus is engaged in the act of trying to get the rock to the top of the hill. He's never going to make it because the curse is that every time he gets to the top, it rolls back down again, okay? And Tantalus is involved in the futile acts of trying to eat and drink, okay? They are futile because they cannot achieve their intended goals. They produce no result. We should point out that futility has to be defined in terms of a particular goal. So for example, if Sisyphus here was interested in getting exercise, then the act is not futile because he's achieving his goal. If his goal is to exercise, weightlifting, if you will. But if the goal is to get the rock to the top of the hill, then it is futile. So you have to define futility in terms of a particular goal. So if that's what futility means, is that it's useless, can't achieve any result, medical futility can be defined as, quote, a medical conclusion that a therapy is of no value to a patient, should not be prescribed. Another way of saying the same thing, interventions are medically futile if they have no realistic chance of achieving their intended medical goal. No realistic chance of achieving their intended medical goal. And that's the definition you should remember, okay? Well, medical futility has been around a long time. It has its roots in antiquity. See, in the Hippocratic writing, The Art, physicians were advised to, quote, refuse to treat those who are overmastered by their diseases, recognizing that in such cases, medicine is powerless. Medicine is powerless. There's even a reference to medical futility in The Godfather. Not so much in the movie. I think it was an outtake. They cut it out. But in the book, there's a point where the old consigliere Genco Abbandando is dying in the hospital. He's dying of cancer, and so Don Corleone brings his sons to visit him in the hospital, and he has an interaction with the physician there, which is kind of interesting, and basically lectures him about the concept of medical futility. So you might want to read the book instead of seeing a movie sometime. Okay, so why does it matter? Why are we even talking about medical futility? And the reason it matters is because there's this maxim or this dictate that's been around forever that futile treatments are not obligatory. This is a quote from the Annals of Internal Medicine. No ethical principle or law has ever required physicians to offer or accede to, which means give in to, demands for treatments that are futile. Now that's not absolutely true anymore, and we're going to talk about that a little bit later. Unfortunately, it's not true. But it's true as a general rule. So physicians and physician assistants are generally under no obligation to provide treatments that are medically futile. So that's why medical futility matters, because it has something. It says something about the standard of care and what I'm obligated to do. These writers, Jecker and Schneiderman, have made the stronger assertion that not only are physician assistants not obligated to provide treatments that are futile, but that in fact they may not do so. They may not do so. They are obligated to resist demands. So, again, medical futility matters because it arguably delimits the sphere of proper unilateral decision-making by physicians. If something is outside of the standard of care or below the standard of care, I don't have to offer it to patients, right? And I don't have to discuss it with them, right? Any questions about anything that we've talked about so far? Okay, so there's a couple of different types of medical futility that people have described, have referred to. And these are the three types here. First, medically futile because ineffective. Second, medically futile because non-beneficial. And third, medically futile because improbable. We're going to talk about each of these in turn. So let's talk about the first one, medically futile because ineffective. A treatment is said to be medically futile because ineffective if it is futile in achieving its physiologic objective and so offers no physiologic benefit to the patient. Another term that's used to describe this category is physiologic futility. We cannot achieve our intended physiologic goal, and so we cannot benefit the patient because we can't achieve the intended physiological goal, physiologic futility. So an example of this is starting CPR in a patient in whom rigor mortis has already set in. The patient is dead, it's going to stay dead, and it makes no sense to start CPR at that point in time. It's medically futile. You can think of many examples of something that would be medically futile. If you knew with metaphysical certainty that somebody had a viral infection, then giving them an antibacterial is medically futile. It makes no sense. Okay? You're not going to benefit the patient because you can't achieve your intended physiologic goal. Yeah.
Someone on life support that's perfect brain dead fall under this?
Well, and doing what? Keeping them on life support?
Yeah.
It depends on what the goal is. Remember, if the
Without
goal,
harvest.
huh?
Not like harvest.
Yeah, if your goal is to harvest organs, it's not futile. But if it's like what, maintaining life? No, it's futile, right? Because there is no life there anymore. So yeah, that would be an example of that. It's medical futility. The second category is something that's medically futile because non-beneficial. So this is an intervention that has important physiologic effects. However, in the judgment of medicine, the medical practitioners, those effects are not going to benefit the patient as a person. This is also referred to as qualitative futility. Qualitative futility. And an example of this would be the use of artificial feeding and hydration, for example, in the Terry Scheibel case. Terry Scheibel, you'll learn about this, you probably know about Terry Scheibel, but you'll hear more about it from Dr. Walker when he comes in about another month. He's going to talk to you about a number of topics, and one of them is Terry Scheibel. He's written and talked quite a bit about Terry Scheibel, so I think you'll enjoy that. Terry Scheibel was a persistent vegetative state, so she had no awareness of herself or surroundings, and that was never going to change. It was permanent, okay? And so, what is the physiologic goal of artificial feeding and hydration in a patient like this? What are we trying to do? Yeah, you're trying to maintain hydration, maintain protein status, maintain electrolytes, all with the goal of maintaining life. So if we can achieve our physiologic goals, the question is, does that benefit the patient as a person? And where the things that basically define personhood are not there anymore, where there is no person anymore, okay? Then you can make the argument that, well, it can't benefit the patient as a person if there's no person there anymore. Now, one of the things that you'll notice about this type of futility is that it's more controversial than the last one. It seems on its face it's going to be more controversial because some people are vitalists, right? And they believe that life, even vegetative human life, is worth maintaining. It's a philosophical position that they hold. And so this type of futility, unlike the first one, it harbors a hidden value judgment. Now we can argue about whether that value judgment is correct or incorrect, okay? But there is at least a hidden value. Everybody see that there's a hidden value judgment in there? If you hold this position, what you're saying is that maintaining a human life in a vegetative state is not a proper goal of medicine. Does everybody see that? And that, to a certain extent, is a value judgment. And so that's why a lot of people object. They have problems with this type of futility, okay? The third type of futility is referred to as quantitative futility. And something is quantitatively futile if it's very unlikely either to produce a desired physiologic benefit or a desired personal benefit. It's so unlikely to work that we say it's futile. Okay? The probability is so low that we say it's futile. So the question then is, well, how low does the probability have to be in order for it to be futile? And again, this is why this is sort of a controversial type of futility. Okay? It makes sense that it would depend on who we're talking about, right? I mean, if we're talking about me, and I have a 1 in 100 chance of it working, I may say, well, that's worth taking. Whereas, if we're talking about you, then I might say, 1 in 100, it's not going to work. Let's not even try, right? And this is the Charlie Brown kick in the football, right? That's sort of an example of this type of futility, right? We all know. We read the cartoon every time. We always look to see whether, well, maybe he'll get it this time. Even he thinks he might get it this time, but he never does. So it's futile. It's quantitatively futile, right? All right. Okay, I'm going to talk. Any questions about any of the different types of futility before I talk briefly about a couple of futility cases? Okay, let's talk about these are early cases, and we'll talk very briefly about them. The first case was the Helga Wangley case in 1990. This was an 86-year-old ventilator-dependent woman in persistent vegetative state, like Terry Schiavo. In November of 1990, her physicians informed her family that that continued mechanical ventilation was non-beneficial and that it should be discontinued. So they were claiming what type of futility?
Quantitative or qualitative?
Huh? Qualitative futility. Mrs. Wangley's husband, who it turns out was a lawyer, her daughter and her son rejected the idea of withdrawing ventilatory support, and they claimed that the patient would not be better off dead, and that after all a miracle could occur. The husband initially told the physician that his wife had never stated preferences regarding life-sustaining treatment in the setting of PBS, but he later insisted that no, I was wrong. She actually did tell me that she wanted respirator support for such a condition. So there's some question about how forthright the husband was being. He was an attorney, and so he may have just been concerned that he might have just been changing the story in order to prevent them from disconnecting his wife from the ventilator. Anyway, the hospital goes to court. They ask the court, the hospital wants to disconnect the ventilator, right? And so what they should have done is gone to court and say, okay, we're going to disconnect the ventilator. Instead, they go to court and they ask the court to appoint an independent conservator to decide whether continued use of the ventilator was beneficial to the patient. In a year later, the court appointed the husband as conservator, and the hospital said, okay, well, that's enough. We're not going to pursue this any further. They said we're not going to discontinue the ventilatory support, but coincidentally, anyway, 3 days later, she died of sepsis-induced multi-system organ failure. So instead of asking the court, can we disconnect the ventilator, they said, appoint a guardian who can make the decision about disconnecting the ventilator. And the court said, well, she has a husband. We'll just appoint the husband as the decision maker. And that's, of course, not what the hospital wanted. They knew that they weren't going to win. So they just dropped it. In any event, she dies of multi-system organ failure. The second case, in the matter of baby K, this is a fascinating case. And remember when I told you that the maxim that there's never been any requirement to provide fetal care, that wasn't entirely true anymore? Well, this is a case that illustrates that it's not completely true anymore. So baby K was an infant girl born with anencephaly in 1992 in Virginia. Anencephaly means that she has a brainstem but has no cerebral hemispheres. Upon being born, she develops respiratory distress. She's intubated. The mother is told that there is no treatment for anencephaly, and the standard of care is that we wrap the baby in a blanket, we give the baby you to hold until she dies, and then it's basically conservative care. Okay. Well, the mother wasn't happy with that. She refused to consent to a DNR order. She refused to let them extubate the baby. Goes to the Institutional Ethics Committee, which concluded that ventilatory support was indeed futile and should be stopped after allowing mom a reasonable time. By the way, which type of futility is this? Huh? It's what?
Physiologically. Improbable.
You can ventilate the baby. So you can maintain your goal of keeping the CO2 down and the oxygen up. So it's not physiologically futile. It's again an example of category 2. Okay. The mom rejects the committee's recommendation. The hospital lucked out, though. They were able to extubate the baby without the baby dying, and so they quickly give the baby to mom, and they discharge the baby. Unfortunately, the baby gets readmitted to the hospital a couple more times the same year, and so the hospital realizes that this isn't going to go away anytime soon, so they have to go back to court. They commence legal action, and a guardian is appointed to represent baby K. The guardian shared the hospital's position this time, that ventilator treatment should be withdrawn, and so the hospital goes to court and asks for a declaratory judgment. Says, we're going to disconnect the baby from the ventilator. We want you to tell us it's okay. And this goes to federal court, and the federal court actually looks at something called the anti-dumping statute, the federal anti-dumping statute, the EMTALA, Emergency Medical Treatment and Active Labor Act. And they said that under the Emergency Medical Treatment and Active Labor Act, if somebody presents to the hospital with an emergency medical condition, then the hospital is required to stabilize that patient. And they said that the EMTALA statute doesn't have a futility exception. So they said if baby K presented to the emergency room in respiratory distress, the hospital would be obliged to intubate the baby. So in essence, what they're doing is ordering fetal treatment. Okay? The other thing that was interesting about the case is that the court said, and anyway, they said, and anyway, even if there was a futility exception, it would not apply here. This is the court's language, quote, "The use of a mechanical ventilator to assist breathing is not futile in relieving the acute symptoms of respiratory difficulty, which is the emergency medical treatment that must be treated by EMTALA." So, what definition of medical futility is the court employing?
Physiologic.
Yeah, the court's buying into physiologic futility, and they're saying even if there was a futility exception, which there isn't, it wouldn't apply. So they're rejecting the qualitative futility. So this was a case that basically imposed a legal duty to deliver futile treatment. Yeah.
I mean, I get that it's like the hospital for like arguing these cases, but what about as like an individual? Like, what if, like, I mean, it's like if I was working at a hospital and I had to constantly try and save a baby that had no brain, like at what point am I allowed to be like, I can't do
Yeah,
this
you're talking about rights of conscience.
Yeah.
You're talking about rights of conscience, and that's an interesting topic. It's going to depend. It's going to depend on lots of things. It's going to depend on in a situation like this. It's going to depend on the nature of your objections. It's going to depend on the availability of other people who are willing to take your place. This is a complicated topic. This is basically similar to what happened in Kentucky recently with the clerk who didn't want to dispense the marriage licenses to gay couples, right? It's a similar thing. We're asking about rights of conscience and where do the rights of the individual professional and their duty to violate their conscience, if there is one, begin. So that's a good question. You can't answer that question in the abstract. You'd have to basically look at the specifics of the situation and try and come up with the best answer under the specifics.
decided by like the hospital?
Say it again?
Would that be like decided by the hospital or?
Well, I mean, you would take it to that first, but ultimately, what you're interested in, if you're a practitioner, right? You're interested in what's the law going to say about this, right? Because that's what the thing that's going to have consequences for you, and what's the board going to say? Certainly, if you're better off, if you're a practitioner and you don't want to do this, let's say you decide, bless you, let's say you decide you're going to take a principled stand, okay? I don't care what they say, I'm not going to do it. Well, if the hospital is against you, and they might be and the ethics committee doesn't take your side, and you're just standing out there like a lone reed in the wind, then you're at some peril. They might even come after your license and stuff like that. Whereas if the ethics committee says, this is futile, and the hospital is on your side as well, and you say, look, I'm not going to do it as a matter of conscience, I'm not going to do it. Then you're better off. I still don't know how that would have come out. But the truth is that most of the time, not always, but most of the time, institutions cave, and it's a non-issue. But you'll see in the next case, you'll see something interesting in the next case, which is the Gilgan case. So in the Gilgan case, the patient was a 71-year-old female with Parkinson's disease, diabetes, heart disease, and she'd had a stroke 1 year prior. She'd had a mastectomy for breast cancer, and she gets admitted to Massachusetts General Hospital. So this isn't just a run-of-the-mill hospital. This is the premier, maybe the premier hospital in the country. Okay, she gets admitted for hip fracture, and she develops irreversible brain damage. But was not, I don't believe she was vegetative. She just had severe brain damage, but was not vegetative. Her daughter insists that her mother had always said that she wanted, quote, everything possible done medically. But the attending physician with the support of the Institutional Ethics Committee, writes a DNR order on the chart, okay? The daughter objects, the order is withdrawn, and the physician writes in the chart, I find it difficult to provide a medical reason to avoid resuscitation that is as powerful as the family's desire to have it done. I find it difficult to provide a medical reason to avoid resuscitation that is as powerful as the family's desire to have it done. You could say that the fact that something is medically futile is compelling reason not to do it, but in any event, 2 months later, a new attending physician, because you know the services change usually on a monthly basis. A new attending physician again asks for and receives from the ethics committee permission to write a DNR order, which is placed on the chart on August 7th, 1989. On August 10th, Mrs. Gilgan was weaned from the respirator and died. So the daughter brings an action against the hospital, and the court rules that Massachusetts General Hospital and the doctors were not guilty of negligent infliction of emotional distress on the daughter, because that's the action that she brought. You negligently inflicted emotional distress on me by disconnecting my mom from the ventilator. The judge asks, interestingly, the judge asks the jury to consider whether the patient, had she been able, would have requested CPR. Right? That sounds like an important question, right? Judge asked the jury, if the patient was able to ask for CPR, would she ask for CPR? And the jury said yes. That's fascinating, right? If the jury had said no, then we would have said, okay, the reason that they approved the discontinuation of the ventilator was because the patient wasn't consenting to it. But that's not what they said. The jury agreed with the defendants that such treatment would have been futile. So the jury, in this case, gave the hospital the verdict that they wanted for the reason that they wanted. They say, we agree that it's futile and it was proper not to keep this patient on a ventilator. In fact, even if the patient had been able, even if the patient had an advance directive that said, I want to be ventilated under those circumstances, we still would have agreed with you. That's fascinating. It's a very strong verdict. So there's a couple of things to take away from these cases, I think. And one of them is that how the case gets to the jury, to the jury or the trial court, makes a big difference. Okay? So you notice the difference between Gilligan and the other cases.
Already dead.
Huh?
Already dead.
Right. It's in the Gilligan case, the hospital is presenting the court with a fait accompli. They're saying, this is what we did. This is why we did it. You have a problem with it. So the courts are going to be more reluctant to second guess, medical practitioners under these circumstances. In the first two cases, they're saying, like, we're going to disconnect her from the ventilator. Are you okay with that? And it's like, what do you mean, are we okay with it? We're lawyers, we're not doctors, right? They don't feel comfortable, authorizing that. So how the case finds its way into the courtroom makes a difference, okay? It also probably made a difference that was Massachusetts General Hospital, if it was some hospital in a tiny little rural town with a medical staff that wasn't particularly well regarded, maybe that the outcome is not the same. Okay, if anybody's interested, you can go to this link here, this site, and there's a whole bunch of information on medical futility cases down through the years, including up until the present. So you can this professor's collected all the futility cases. And there are even futility statutes now. So states have begun writing futility statutes to address the situation. What happens if you have a situation like arose in Wangley or Gilgan or Baby K, and the doctors don't want to treat, and the family wants treatment. what do you do? So you could look, for example, at the Texas statute, which is maybe the most famous one, okay, which actually sets up a procedure for how to deal with these feudal situations. Anybody here from Texas? Okay, all right, so are you guys familiar with the Texas statute? But it sets up a procedure for doing it, and if you want to discontinue treatment, how does medical provider, how do you go about doing it? Okay, so there's some hoops that you have to jump through. So you can take a look at that statute. I think this statute is also on this website. When you get to this page, you'll see on the left-hand drop-down menu, you'll see futility cases, futility statutes. Just click on futility statutes, and it'll bring up the different statutes. Okay, and Texas is only one of the states that has medical futility statutes, but it has a very good really good statute, physician-friendly statute. So you may want to take a look at that. Okay, so that's the end of the detour or digression. Remember, we started our discussion of medical futility by saying that when you talk about the internal morality of medicine, and you talk about things that violate the goals and things that violate the means, medical futility seems not to fit into either one of those categories, but it's still a problem. Okay? Medical futility does not fit neatly into either category. So let's think about it, okay? Baby K. Anencephaly, okay? The doctors are arguing that it's medically futile, okay? So let's think about, so that the treatment would run afoul of the internal morality of medicine. It violates the internal morality. I should not treat this baby, right? Remember Jecker and Schneiderman said that they took the very strong position that if something's medically futile, not only are you entitled not to render treatment, but you may be obligated not to render treatment. Okay? Well, if that's true, then how do we square that? How do we explain that using the language of the internal morality of medicine? What's the goal in baby K? Ventilating the baby. We can achieve some medical goal, right? We can prevent death, okay, maintain life. You go back to the goals. So there is a goal that's achievable. Yeah.
Did you say that in that case the court ruled that medical intubation was a form of stabilization?
Right.
They ruled that? I didn't sure I heard that.
Well, they said what they said was that the hospital had to do whatever was necessary to stabilize the baby who presented with respiratory distress. That might include intubation, yes.
They found that to be stabilization.
Right. So you have a goal, and what about the means? Intubation and mechanical ventilation. That sounds like something that we do all the time, right? We're using a skill and knowledge about how to adjust the ventilator settings that you learn about in med school or PA school or in training. So if the goal is legitimate, there's a legitimate goal that can be had, and the means are appropriate medical means, then why is medical futility, why is there a problem with the internal morality of medicine? That suggests that there has to be a third category besides goals and means, okay? And in fact, the third category is the space in between goals and means. It's the nature of the fit between the goals and the means. You can find precedent for this in the analysis that is employed by American courts when they review the legitimacy of legislative acts. So, for example, when the Congress or the legislature, whichever legislature you want to talk about, passes a law that affects a fundamental right, like the right to vote or the right to travel between states, those regulations are reviewed under what's referred to as a strict scrutiny standard, which means that they get struck down unless the regulation is necessary to achieve a compelling government purpose or interest. So the means the means that the legislature chooses must be necessary to the goal that it has selected. And it's got the goal that it's selected has to be compelling. All right? If the legislature is just legislating in a way that doesn't affect any fundamental rights, okay? You can't drive faster than 70 miles an hour on the highway. That doesn't affect any fundamental rights, okay? Or that, you know, the tax rate's going to be 30% instead of 25%. Doesn't affect any fundamental rights. Then the only thing that they have to do is make sure that they meet what's called a rational basis test. The laws will be upheld if they're reasonably related to a legitimate government purpose. So, again, just to clarify the nature of the relationship between the means and the ends, if you're dealing with strict scrutiny, if you're dealing with fundamental rights, strict scrutiny is employed, and the relationship between the means and the ends is that the means must be necessary, absolutely necessary. You can't achieve the goal except by using these means, and the goal that you've picked out has to be compelling. It has to be really, really, really important. Under the rational basis test, okay, it just has to be a legitimate goal. It doesn't have to be a compelling goal. And the means don't have to be necessary. There may be 10 ways to do the same thing, 100 ways to do the same thing. As long as it's reasonable, what you did, what the legislator did, then the court will uphold it. All right. So the point here is that the tightness of the fit between the means and the ends can vary, right? Depending on what goal we're trying to achieve. Well, medical futility, if you think about it, is the poster boy, the poster whatever, of means ends disconnection. Okay? In medical futility, the means and the ends are not appropriately related. Okay? In fact, there's a complete disconnect between the means and the ends with medical futility. The means that you've chosen cannot achieve the goal that you've chosen. You see that? So it can't be rational. It can't even meet the lower standard, which is rational basis, because you cannot achieve the goal that you've selected using the means that you've selected. Everybody see that? So the problem with medical futility is not the goal, and it's not the means. It's the means ends disconnect. Everybody see that? I'm going to give you some examples in clinical practice that illustrate this, okay, when we come back, so it'll make more sense. Take a 10-minute break.